Anemia is defined as a decrease in erythrocytes and hemoglobin, resulting in decreased oxygen delivery to the tissues. The anemias can be classified morphologically using RBC indices like MCV, MCH, and MCHC. They can also be classified based on etiology or cause. Anemia is suspected when the hemoglobin is less than 12 grams per deciliter in men or less than 11 grams per deciliter in women. Relative or pseudoanemia is a condition where the RBC mass is normal, but plasma volume is increased. This type of anemia is secondary to an unrelated condition and can be transient in nature. Causes include conditions that result in hemodilution, such as pregnancy and volume overload. In relative anemia, the reticulocyte count is normal, and it presents as normocytic and normochromic anemia. Absolute anemia occurs when the RBC mass is decreased, but plasma volume remains normal. This indicates a true decrease in erythrocytes and hemoglobin. The mechanisms involved in absolute anemia include decreased delivery of red cells into circulation, which may be caused by impaired or defective production. In such cases, the bone marrow fails to respond, leading to reticulocytopenia. Another mechanism is the increased loss of red cells from the circulation, which can be caused by acute bleeding or accelerated destruction, known as hemolytic anemia. Here, the bone marrow can respond, resulting in reticulocytosis. Impaired or defective production anemias occur when the bone marrow is unable to produce red cells effectively. This can be due to a variety of underlying conditions that impact the production process. Iron deficiency anemia is, well, the most common form of anemia in the United States. It's particularly prevalent in certain groups such as infants and children, pregnant women, those with excessive menstrual flow, and the elderly with poor diets. Additionally, it can occur in individuals with malabsorption syndromes or chronic blood loss, like from gastrointestinal bleeding or hookworm infection. In terms of laboratory findings, iron deficiency anemia is characterized by microcytic and hyperchromic anemia. You'll see low levels of serum iron, ferritin, hemoglobin, hematocrit, and red blood cell indices, as well as a low reticulocyte count. On the other hand, red cell distribution width, RDW, and total iron binding capacity, TIBC, are typically high. A blood smear might show ovalocytes or pencil-shaped cells. Clinically, the symptoms can be quite varied. Common ones include fatigue, dizziness, and pica, which is a craving for non-food items. Stomatitis, or cracks in the corners of the mouth, glossitis, which is a sore tongue, and koilonychia, or spoon-shaped nails, are also frequently observed. Anemia of chronic disease, often referred to as ACD, is due to an inability to use available iron for hemoglobin production. This condition is characterized by impaired release of storage iron, which is associated with increased hepcidin levels. Hepcidin is a liver hormone and a positive acute phase reactant. It plays a major role in body iron regulation by influencing intestinal iron absorption and the release of storage iron from macrophages. Now, inflammation and infection cause hepcidin levels to increase, and this in turn decreases the release of iron from stores. From a laboratory perspective, ACD can present as normocytic, normochromic anemia or slightly microcytic hyperchromic anemia. You might also see increased ESR, normal to increased ferritin, and low serum iron and TIBC. This condition is often associated with persistent infections, chronic inflammatory disorders such as systemic lupus, erythematosus, rheumatoid arthritis, Hodgkin lymphoma, and cancer. Anemia of chronic disease is second only to iron deficiency as a common cause of anemia. Sideroblastic anemia is caused by blocks in the protoporphyrin pathway, resulting in defective hemoglobin synthesis and iron overload. This excess iron accumulates in the mitochondrial region of the immature erythrocyte in the bone marrow and encircles the nucleus, forming cells called ringed sideroblasts. In mature erythrocytes in circulation, excess iron accumulates in the mitochondrial region, and these cells are known as siderocytes. The inclusions here are siderotic granules, also called Pappenheimer bodies, on right-stained smears. Siderocytes are best demonstrated using Pearl's Prussian blue stain. There are two types of sideroblastic anemia: primary, which is irreversible with unknown causes of the blocks, and secondary, which is reversible and can be caused by factors like alcohol, anti-tuberculosis drugs, and chloramphenicol. In the primary type, two red blood cell populations or dimorphic populations are seen. This is one of the myelodysplastic syndromes, specifically refractory anemia with ringed sideroblasts, or RAS. In the laboratory, sideroblastic anemia typically presents as microcytic, hypochromic anemia with increased ferritin levels. Lead poisoning, it's quite a significant concern, particularly in children. Multiple blocks in the protoporphyrin pathway affect heme synthesis. This condition is mostly seen in children who have been exposed to lead-based paint. Clinical symptoms include abdominal pain, muscle weakness, and a gum lead line that forms from blue or black deposits of lead sulfate. In the laboratory, lead poisoning presents as normocytic, normochromic anemia, with characteristic coarse basophilic stippling. Porphyrias are a group of inherited disorders characterized by a block in the protoporphyrin pathway of heme synthesis. Heme precursors before the block accumulate in the tissues, and large amounts are excreted in urine and/or feces. Clinical symptoms of porphyrias can include photosensitivity, abdominal pain, and central nervous system disorders. However, the hematologic findings in porphyrias are generally insignificant.